And you're back with the Rocket Right Show. I'm Dr. Kay Solar in the house with Hurricane Betsy Barnes. And our medical segment is brought to you each week by Mary Bird Perkins, Our Lady of the Lake Cancer Center. And we are so glad to have with us Dr. Keith Rhynes.
Thank you for having me.
Us.
Thank you.
Dr. Rhynes is a surgeon, and he's been here a long time, as long as I've been here. Might even
5 years, right? 5 years?
5 years. Yeah, that's it.
That's right.
We just finished school, and we just moved to town. They say, no, that's a lie. I was like, how long has it been? It's been
22.
I was going to say, yeah.
22 years.
Yeah. Isn't that crazy?
Lots changed. Lots developed. A lot in healthcare.
So he's taking care of a lot of folks during this time. I've worked with him for all of those years, seeing patients, consulting over at Women's Hospital. He's at Mary Bird Perkins, Our Lady of the Lake Cancer Center, and we're focusing today because April is Esophageal Cancer Awareness Month. And so just talk about that disease a little bit. I'm just going to open up the floor for you.
All right. So I think most people know what the esophagus is. It's that muscular tube that connects our throat into our stomach, and we swallow, the food goes down there. It contracts and pushes the food down, so it's obviously important.
Yes.
The esophagus has a propensity to develop a malignancy. There are multiple layers of the esophagus. The esophageal cancer forms on the inner lining of the esophagus and then subsequently starts to grow out through the other walls of the esophagus. Unfortunately, it can grow into the surrounding structures, which can be the lungs, the liver, blood vessels, etc. So it's a difficult cancer to treat. But we made a lot of progress over the last 10 or so years.
Absolutely. We're going to talk about some of that a little bit later on. But if somebody's listening, they go, well, I mean, how would you even know that you thought you might have esophageal cancer? What are some of the signs and symptoms that someone could be experiencing that would let them think, oh, I bet I need to check that out?
So the first symptom that a patient may experience is a difficulty in swallowing. They may feel like their food, their sandwiches, their bread is getting caught within their chest when they swallow. In advanced stages, even liquids can get caught. Some patients may have anemia. They may see some blood in their bowel movements as these things slowly start to bleed. Some of the symptoms are very, very, very subtle. Weight loss, unfortunately, can be a symptom of an advanced stage. But swallowing dysfunction is primarily is the first symptom that should present.
So do they ever have a sore throat that's associated with this, or is that uncommon?
That's actually uncommon. The sore throat is usually from the reflux that they may be experiencing, which then, as we'll talk about later, increases their rate of developing esophageal cancer.
Yeah, so let's talk about some of those risk factors since you brought that up.
So there's actually two types of esophageal cancer. The most common back when we were training was called squamous cell carcinoma. Risk factors for that are genetics, alcohol, and tobacco. Patients who mistakenly drank some caustic fluids like lye. The second most, and now the most common type of esophageal cancer is called adenocarcinoma. And the risk factors for that, also genetics, alcohol, tobacco, obesity, which increases your rate of reflux. Reflux is probably the fastest growing risk factor for developing esophageal cancer. Reflux, when the acid contents of your stomach reflux back up in your esophagus, and the esophagus just doesn't like that. So it burns it, and slowly the cells begin to change into pre-malignant cells and then subsequently a malignant cell.
Now, do you think that the increased rates of obesity in the country, and so increased rates of probably reflux due to that, is why we're seeing more adenocarcinomas than the squamous?
Absolutely.
As in the past?
That's 100% accurate. That's correct.
Wow.
So
That's
could it
crazy.
be just poor diet, overly processed foods, those types of things? Or would it help if someone was overweight, if they found out maybe they were diabetic or something like that, they had another comorbidity or another, thing that maybe they're just not even aware of?
So processed food is actually a risk factor as well as smoked foods.
You mean like smoked sausage and ribs? And
Yes, Betsy.
Right.
I know.
I know.
I gotta ask.
I like smoked salmon. I was like, I'm being so healthy. I'm eating smoked salmon, and then I said, the smoking is not so good for you.
So,
Yeah,
but that's
even though
a
you're
risk
eating healthy
factor for
fish.
sure.
But you'd have to ingest a lot, it would seem.
Absolutely, and it's just the nitrates within the meat. So.
So when we're talking about those risk factors, and you know, somebody says, well, like, can you prevent yourself from ever having it?
Yes.
Let's talk about the prevention.
So prevention, reduction in alcohol, reduction in tobacco, avoiding becoming obese. If you begin to have reflux type symptoms, heartburn, go see your gastroenterologist, get put on the proper medications, have them do an endoscopy to treat you medically for your reflux. Again, that's the most common risk factor that's increasing in the world. And so if we can treat that medically before it becomes pre-malignant, then that's a huge step in preventing it.
Right. So many folks, they just don't realize, we've talked about it on a lot of things, as that being overweight really increases your risk of so many things.
Correct.
As it does this one. But now let's say somebody's diagnosed with esophageal cancer. You talk about we've come a long way as far as advancements in the treatment for this.
Correct.
So let's talk a little bit about that.
So once it's diagnosed, the treatment diagnosis of esophageal cancer is a team approach. It's usually picked up by primary care, gastroenterologist, and then you begin staging with CAT scans and PET scans. Unfortunately, the majority are a little bit more advanced, so the majority do not go to surgery first. The majority will then go to the medical oncologist to get chemotherapy, followed by radiation. So now we've got a team of primary care, gastroenterologists, medical oncologists, radiation oncology, and then about 6 to 8 weeks after the radiation is completed, that's where the surgeons get involved to remove the tumor, which 25 years ago was a pretty morbid, difficult procedure, which we did, and the patients did well. Now in 2021, we can do most of these procedures, if not all, robotically, minimally invasive. Surgeons being the thoracic surgeons, Dr. Nick LeBlanc, Dr. Emily Cassidy, and the abdominal surgeons, Dr. John Rhynes and myself. We can do this robotically through 3 or 4 small holes in the abdomen, 3 to 4 small holes in the chest. The surgery is real. People hear that, oh, you've got these small incisions, but you actually remove the entire esophagus and bring the stomach up into the chest.
Yeah, people don't realize you got a couple of small holes, but
Right.
all the same big work was
Right.
done on
It's
the
the same-
inside. You just don't have the big incision
That's
to
correct.
show for it.
But it's a lifesaver, and it seems that it would be reducing the amount of time that they would have to recover.
Oh,
You know.
they will go home in 5 to 6 days compared to 2 to 3 weeks.
That's
It's
a huge
It's a
difference.
huge difference. So they get back to their jobs quicker. They get back to their families quicker. And they're just doing better from an oncology cancer survival standpoint.
And the reason that they have to have, most of them are picked up later. Maybe the symptoms are very subtle, so they don't present until they have
Correct.
advanced disease. And then you have to do the chemo and radiation. Is it to reduce the size of the tumor to make
Correct.
it more amenable to surgery?
Correct.
Is
So
that
keep-
why that's needed in advance?
Absolutely. So the oncologist, the medical oncologist at Mary Bird Perkins will give chemotherapy, which will then treat systemically, which will treat any esophageal cancer cell that's floating around anywhere else. And that's followed by the radiation oncologist at Mary Bird Perkins, who will treat locally to reduce the local invasion. And then again, 6 weeks later, once the after effects of the radiation have kind of resolved, then that's when we get involved.
Yeah. So let's talk a little bit about, because I know people have in their brains, they'll be, I want that robot surgery. And they just feel like there's a robot doing their surgery. And talk a little bit more, like if somebody's seeing that, oh, they offer robotic surgery. Is Dr. Rhynes doing that surgery, or is there some robot in there? And is his name Da Vinci? Talk about that.
So
I mean, it's true.
That's true. It's a
Because
very-
when you see advertisements, it's very confusing.
Right.
So
That's a very
we don't
common
have
question.
much time, but I want you to explain that.
It's a very common question. So the Da Vinci robot is the most common device that we use to do these types of procedures. So simply what happens is the patient is put to sleep. We put these small little instruments in the abdomen. We connect the instruments to the arms of the robot. And then we go sit down in a very nice, comfortable chair, looking at a almost 4D monitor, and we can control the instruments with our hands and our feet, and we can really get into small areas. We can do small little maneuvers that we just couldn't do, as you remember.
Right, you just
with our
couldn't do
laparoscopic instruments.
With laparoscopic instruments, or even if you're in there, like with the person open, you can just get in such little spaces more delicately around those structures that are around the esophagus, which are very important.
Correct. It's much more precise.
Absolutely.
Which then your precision reduces the complications, which allows for a better cancer procedure.
Well, Mary Bird Perkins always does such a great job with working with patients from the very beginning to the screening, the diagnosis, and then holding their hand through it. And we're always fascinated with what you're able to do.
There's dietitians, there's pharmacists, there's patient navigators.
Well, all those things that help you have not just a better recovery, but a less chance for recurrence.
Correct.
Yes.
Because if you adjust your diet and some of those things that are risk factors, you can have a less chance of that recurring. So if y'all are listening, you want to know more, you can go to marybirdlake.org/esophageal. And thank you so much for being our guest, Dr.
Thanks for having us.
Rhynes.
Thanks for letting us bring this
We are
out to the public.
glad that you came and have such great expertise.
Thank you. Nice to meet you.
Nice to meet you.
All right, and up next, Miss Abby Lee playing us some music, so don't go away.